Hi, everyone. Welcome. Thank you for the invitation, everyone, and thank you, David, for leading this initiative for 5 years. Congratulations on the work well done. I will today talk about our project that has been recently granted support from OICR, and it's called Distinguishing Aerogenous Metastasis from Multiple Primary Adenocarcinomas, a multidisciplinary proof of concept study. This study, I am the PI. Matt Sung is our resident who is working with us, and Bryan Lowe is the molecular pathologist, geneticist who is working, the molecular geneticist that is working with us in this project. So first disclosure, I was saying I'm not a scientist, I'm a clinician and an educator. I do a little bit of research that is clinically applied, and usually for me to be able to do this research, I work in collaboration with real scientists like Bryan Lowe and the scientists here at OHRI, the Ottawa Hospital Research Institute. And that's what I do mostly, collaborative research. So what I'm going to bring to this discussion now is the clinical perspective. It's really our clinical question. And then Bryan, if he's able to join us, I'm not sure, let's see. If he's able to join us, he's going to talk about the methods. If he's not able to join us, I will talk about the method. Oh, you're here. I'm sorry. Thank you, Bryan. Welcome. So, okay, great. So let's start. So what is the background? So here is a CT from an elderly man who presented with non-resolving left lower lobe consolidation with surrounding ground glass opacities. Biopsy of the lesion revealed papillary adenocarcinoma. After further workup, the lesion was treated with left pneumonectomy. So let's translate everything that is written here. I know that we have an eclectic audience here today, and things might not be clear on the imaging and pathological side. So here we see the chest CT. So this is the right lung, this is the left lung, and the lung is usually black. And here we have this white tissue in the posterior aspect, close to the spine. Here we see the heart, this big rounded thing here. And the lung is, part of the lung is completely replaced by this white tissue that here is homogeneously white, and here is more of a hazy attenuation. So this homogeneous white is the areas of consolidation. So the air spaces are filled by something. And those that have a hazy attenuation, like in the yellow arrows, have a partial filling, have partial filling of the airspace by something, or partial displacement of air from the air spaces. And that's why they show with these aspect. So a biopsy was done, and it showed an adenocarcinoma, papillary subtype. So adenocarcinoma is one of the 4 main types of lung cancer, which is the most common and the most lethal type of cancer worldwide. And I work closely with these patients here at the Ottawa Hospital. So this patient was treated with a pneumonectomy, and which means the entire, if you look at the right of the screen, to the right of the screen, the entire left lobe was removed. And a few months later, what we see in the right lung is a bunch of those ground glass opacities, okay, with what we call some tree and bud appearances or pattern, some centrilobular nodules, and here more of that consolidation, that it's kind of white. So this is, when we look at that, there are 2 options usually that radiologists are going to think of, either infection, or it could be what we called aerogenous spread of cancer. However, the concept of aerogenous spread of cancer is not well defined and not well established or accepted in the literature. So the purpose today, I'm going to explain a little bit the mechanisms of aerogenous spread. I'll illustrate characteristic imaging and pathological features, disclose some predisposing factors, discuss the uniqueness and importance of this finding, and describe on the impact on clinical management. And then I'm going to hand it over to Bryan Lowe to talk about our how we want to prove that aerogenous spread do occur, and how we can distinguish it from other types of multiple primary tumors in the lung. So the pathways of intrapulmonary metastasis from a lung primary cancer is either hematogenous spread, so via blood vessels. It's related to vascularity and vascular invasion, and increases the chances of systemic disease, distant organ metastasis. The mechanism, as you know, is local invasion, survival in systemic circulation, extravasation in secondary sites, and establishment of metastatic lesion. And when we look in pathology, what we're going to find is a cancer. And here, I'm not explaining the details of adenocarcinoma. This is an adenocarcinoma. There is a blood vessel here. And within the blood vessel, we see cancer. So this is a classic example of cancer invading a blood vessel, and which could eventually cause a distant metastasis or even an intrapulmonary metastasis. Okay, a second pathway of spread would be the lymphatic route. Okay, so it's usually associated with regional disease and lymph node metastasis, but could secondarily give birth to distant organ metastasis, because the disease can go through the thoracic duct, get into the blood circulation, and then spread to the blood vessels. So that's what I just explained. So either regional spread through the lymphatics to the lymph nodes, or distant spread when it goes to the lymphatic systems, or through major lymphatics to distant sites in systemic circulation. So here we see a lymphatic vessel, and within this lymphatic vessel, we see cancer cells within the lumen of the lymphatic vessel. The third type that is not well accepted that we are proposing is aerogenous spread. So it's spread via the air passages. So that's it's not associated, it would not be associated with an increased risk of distant metastasis, but an increased risk of metastasis within the lung. So discontinuous spread of tumor within the lung. So the mechanism, the putative mechanism, would be neoplastic cells proliferate at the alveolar lumen, shedding of neoplastic cells within alveolar air spaces, then anoic is resistant, so they resist to death when they are anchorage independent. So anchorage independent survival, those cells survive even though they are not attached to the basement membrane. Then seeding of neoplastic cells through the airways network in the other alveoli of the same or contralateral lung, and new distant lung neoplastic deposits with continued cell proliferation. Usually, it's our observation in our group that cases associated with aerogenous spread are more commonly of mucinous, are frequently adenocarcinomas, and usually either of mucinous phenotype or a papillary type of adenocarcinoma. So here's an example. So we see this is far away from the primary tumor, and we can see a bronchiole with tumor floaters or tumor cells or islands of tumor cells within the lumen, and also within alveoli close to this bronchial structure. So if it is not attached and not invading the stroma, so this cannot be by hematogenous or by lymphatic route. It needs to have come through the air spaces. And it's by this observation that the idea of aerogenous spread started to be considered. So let's take a look at how these different diseases look from a clinical perspective. So when we have hematogenous spread, the imaging findings is going to be of multiple nodules in a random distribution in the lung, lower-low predominance, and usually in the periphery of the lung. And they have smooth margins. So if I show an example, as you can see, multiple nodules, rounded, white, which means they're solid, very well circumscribed, and distributed randomly within the lung. When we have lymphangitic spread, we are going to have thickening of the bronchovascular bundles, asymmetric thickening of interlobular septa, and perilymphatic nodules. So if I show an image, what we are seeing here, these are the interlobular septa, which are thickened. So these lines in the lung that we can see, usually in a normal lung, we wouldn't see these lines which represent the interlobular septa. Here you can see normal lung and we don't see lines, but here they are very prominent. And also we see a bronchus here, and the soft tissue surrounding this bronchus is thickened. And this is the peribronchovascular thickening that we see when we have lymphangitic carcinomatosis or lymphangitic spread within the lung. And what are the characteristic CT features of aerogenous spread that have been described in the literature by those authors who propose aerogenous spread? So they are multicentric, multilobar, bilateral involvement. We often see centrilobular nodules with multicentric consolidations in air bronchogram, ground glass opacities, tree in bud opacities, and bronchial mucus plugging associated with increased risk of metastasis. So what I want to say by that is that the radiological features are quite distinct when we think of aerogenous spread. So here's an example. This is a patient who had this consolidation that initially was thought to be infection. The patient was treated with antibiotics, and instead of disappearing the lesion as a patient with infection would have had, the lesions progressed. And they progressed, as you can see, there was a small nodule in the initial CT on the left, and now these nodules grew much bigger in a period of 2 months. So in a very it was a very fast progression that we would not expect if we had synchronous lung adenocarcinomas, but it was also slower than we would expect for progression of a pneumonia. Pneumonia would progress or disappear in a matter of weeks, a couple of weeks. But here, after 2 months, we see progression, no response to antibiotics. So this is very unusual, and this is what we typically see in patients with aerogenous spread. When we look at the histology of these patients, the majority of these cases have a particular pattern in histology, which is the mucinous pattern. So the cancer cells have these intracytoplasmic vacuoles, as we can see here, with a small nuclei that is displaced in the periphery of the cell. Another pattern that we see is this papillary pattern. So we have a fibrovascular core that is lined by epithelial cells. And these papillary features are also frequently associated with cases with aerogenous spread. Here we can see a patient that had a nodule in the right upper lobe, which is in the left upper lobe, which is not shown. But we could see in the right lower lobe here on the left of the image, at the same time that we had this invasive mucinous adenocarcinoma in the other lobe, we could see these very subtle ground glass opacities in the right lower lobe. So contralateral lung. But on follow-up scan, the nodules progressed and became more solid, and it was further proved to be metastatic adenocarcinoma. But again, not forming the nodules that we see in vascular intrapulmonary metastasis. These are some of the features that we can see. So here on the left, as you can see, is the right lung. There was a cancer in the right lung. And in the left lung, here in the center, image number letter B, you can see that there was nothing in the contralateral lung. However, 3 months later, after resection of the right lung tumor, the disease progressed. And once again, as airspace disease, not as a solid nodule. Okay, so I think I can cut short here the different features of aerogenous spread. I think I already made the point that clinically we see something that is different, and the clinical impact is that hematogenous and lymphatic spread are associated with increased chances of regional or systemic spread. On the other hand, aerogenous metastasis seem to be an organ disease or local disease because of the absence of systemic dissemination via blood vessels or lymphatic route. One retrospective study showed significantly better disease-specific survival in patients who had only intrapulmonary metastasis than in patients with lymphatic and hematogenous metastasis. And the importance of the investigators also noted that relapsing treated patients with aerogenous metastasis occurred with intrapulmonary disease, not in distant organs, not as systemic disease. So the importance here is that the aerogenous nature of metastasis in the same or contralateral lung could change the staging of the disease and also the management. And imaging features suggesting aerogenous of spread of tumor negatively impact survival and is independent of other staging parameters. Phenomenon of aerogenous tumor spread remains under-recognized and unconfirmed. When we published our review paper on this topic, 2 of the reviewers said, oh, everyone knows that aerogenous spread occur. And the other 2 reviewers said, this is heretic. How can you say that aerogenous spread exists? So that's very interesting that it has not been established with a proof of concept study. Imaging features are helpful in differentiating possible aerogenous spread of tumor from synchronous primary tumors and vascular metastasis. And aerogenous spread of lung cancer has staging, management, and prognostic implications. All that being said, there are some references here that I'm not going to talk about. What I wanted to bring up to the discussion today is that what we decided to study in this study with OICR is that we wanted to prove that aerogenous spread does occur. And how are we going to prove that? We are studying multiple primary tumors. So we have selected paired tumors. We have identified paired tumors in the lung with 3 different types of pattern. Patterns typical of aerogenous spread, and we have both the primary and the metastatic lesion to study. Multiple tumors when they correspond to synchronous primary lung adenocarcinomas. So we have a primary tumor and a synchronous primary tumor with features that are consistent, radiological and clinical radiological and pathological features consistent with multiple primary tumors. And we have a third group, which is primary tumors that we have both multiple tumors that we have both the primary and the metastatic tumor resected, but they have features, radiological, clinical, and pathological, of vascular metastasis. And we want to study these paired tumors, do a molecular characterization of these tumors. First, to prove if they are, in essence, related tumors or unrelated tumors. So to prove they are metastasis or synchronous primaries. And second, we want to characterize what are the common molecular changes that we have in these different patterns of tumor development and spread. And so I would like to welcome any questions if we have now, or maybe Bryan could talk a little bit. Yes, I think we have a question in the chat. Let me see if I can open that. Can you demonstrate aerogenous in graft? Yeah, so there is, yes. So there is a study, a preclinical study that was done that they instilled neoplastic cells through the airways of mice, and they showed that the tumor would grow and establish metastasis, which would grow over time. So that has been demonstrated in a mouse. But we could find, if I remember well, it's been a while that we wrote the review paper, we could find only one study and using this technique that proved that it could be done. Any other question?
Marcio, it's David. I was hoping you could expand on, if you can, if these information exists on the clinical importance of determining aerogenous versus hematogenous spread, I would have thought, just intuitively, that if I had to pick one for my own lung cancer, it would be aerogenous, just because the tumor hasn't demonstrated the capacity to metastasize throughout the body. Is what's known about these tumors, does that support that? Or?
Yeah, so that's a very good comment. So David, yes, patients, when they compare patients with aerogenous metastasis to patients with vascular metastasis, patients with vascular metastasis did worse. However, even though they did worse, patients with aerogenous metastasis was an independent bad prognostic factor. So patients with aerogenous metastasis or no aerogenous metastasis, they would have a worse prognosis as well. So what I would say is, yes, if you have a lung cancer, it would be better not to have metastasis. If you have metastasis, it would be better to have aerogenous metastasis than to have vascular metastasis. So that's one thing. The other important implication, I think, is that since the pathway of spread is completely different, the way that you should stage and manage should be different. Like we know that maybe like aerosolized treatments could be an idea for patients who have aerogenous metastasis, because you would increase the delivery of the drug just to the diseased area. You don't need to generate toxicity in the rest of the body. So if you had an agent that you could aerosolize and that was not absorbed by by the capillaries, it could be a way to treat those specific tumors. Another idea that came is, could we treat them with transplantation? Because if there is no distant metastasis, and if you remove the lungs, then the patient might be cured. So there are some implications.
It's fascinating.
There is another question. What is the approach that you aim to take to characterize the traits that are associated with different mechanisms of lung cancer spread? Whole genome sequencing? Very good questions. To hand it over to Bryan. Thank you very much.
Yeah, thank you, Marcio. Do I have like 5 minutes, basically?
6.
6. So am I sharing the appropriate screen? This is my...
Yes, we can see your...
Okay. And it's good. I only have 3 slides because 6 minutes is not a lot of time. The approach in our grant proposal was to apply the Oncomine Plus assay. And the background is, 7 years ago when, Marcio and I talked about this erogenous spread phenomenon, we clearly didn't have any capacity to offer local, molecular analysis that could establish erogenous spread as a phenomenon that's real. But we have now, in our clinical lab, which has its protocols in place so that instrumentation can be used for research purposes, we have now, access to the Oncomine Plus assay. And this all began actually with a detailed consultation with Jane Bayani and John Bartlett. I'm not sure if they're on the call. And we really benefited from their experience looking at the Oncomine Plus versus the Ion AmpliSeq exome, because what we wanted to do was basically establish clonality on these FFP specimens. And so the recommendation from Jane was that we seriously consider the Oncomine Plus assay. So this, in brief, is an assay that provides a sequencing of about 500 unique genes. There's enough sequencing real estate to derive mutational signatures. So there's greater than 1 megabase of exonic footprint to do things like a tumor mutation determination. There's coverage of microsatellites, coverage of HRR pathway genes, and ability to annotate complex variants as well as loss of function variants. And for us, the workflow is an automated one. So very quickly, our plan, but this is definitely up for discussion, and perhaps the bioinformatics expertise at OICR can help us in the analysis. But our our plan in the grant proposal was simply to use the clinality R package, and of course available in Bioconductor. We have Ted Perkins here at OHRI, sort of able to apply the Oncomine Plus data to this clinality package, and it's actually undergone a variety of updates. And so in 2019, I believe there's now streamlining of this package to allow comparison of somatic mutation data. I believe, although I haven't seen it, there's also possible LOH data inputs that can be done. We think that with sufficient, tumor cellularity enrichment, like high tumor cellularities using automated microdissection, we should be able to also incorporate some of this data for clinality assessment. And then, of course, using tumor mutation profiles in the clinality calculations. But of course, Marcio alluded to how the secondary sort of objectives include, identifying driver mutations that might be associated specifically with erogenous spread. There was an intriguing, paper by Chang and Reckman in 2019 that they didn't take into account erogenous spread, but in comparing, multiple primaries to intrapulmonary metastasis, there was an enrichment of, MET exon 14 skipping mutations in the intrapulmonary metastasis cohort. And of course, in completing this study with the support of OICR and OMPRN, I think we do, and we can discuss this, have a valuable cohort of specimens for other biomarker studies, including transcriptome profiling. So I just want to end there so we have a bit of time to discuss.